Hello, good evening. Today we will study the topic of SIADH. So, in SIADH, there is an increased release of ADH due to the various etiology, and that leads to the dilutional hyponatremia. So, first of all, we will study what is the etiology of SIADH. It is due to the excessive secretion of ADH either by hypothalamus or there is ectopic production of ADH by cancer. There could be potentiation of ADH effect by chlorpropamide, and due to the increased ADH release can also be due to the head injury, and there are certain drugs that also causes increased ADH like carbamazepine and cyclophosphamide. If we talk about the pathogenesis of SIADH, whenever there is a release of in SIADH, there is a release of ADH which is independent of increase in serum osmolarity, or there's a hemodynamic stimulus. Normally the ADH is released whenever there is increased serum osmolarity or whenever there is a decrease in the blood pressure, but in SIADH it is released independent of normal osmotic or hemodynamic stimulus. So what this ADH does, it will act on the principal cells, and that leads to the absorption of the free water, and therefore the free water cannot be excreted, and that leads to the retention of the free water, and as the free water retains, that leads to the dilutional hyponatremia, and this increase in the free water leads to expansion of both intracellular as well as extracellular fluid. Expanded extracellular fluid now leads to the increased secretion of the ANP, that is atrial natriuretic peptide, and decreased secretion of aldosterone. And what this ANP does, it leads to the natriuresis. So there is an increased loss of sodium in the urine, and there is an increased absorption of the free water from the urine. And all this leads to the increase in the water in the plasma, and that leads to the dilutional hyponatremia, and because this water is retained, the urine pass will be the concentrated urine. Now, what is the diagnostic criteria of SIADH? So for making a diagnosis of SIADH, first of all, you should assess the volume status of patient. The patient should be euvolemic. There should be no signs of dehydration, and there should be no signs of volume overload. Secondly, the patients will be having hyponatremia with hypoosmolality because of excessive water retention. So if you measure the serum osmolality, and usually it is less than 280, and if you measure the urine osmolality, so it is usually higher, more than 100 milliosmol per kg, because of water retention due to the effect of ADH, the urine osmolality is increased. And if you measure the urinary sodium, so it is more than 20 milliequivalent per liter, and you have to rule out other causes that can cause hyponatremia like hypothyroidism, hypoaldosteronism, renal failure, and the diuretic therapy. The patient should not be using any diuretics. If the patient is in renal failure or diuretic therapy he is using, then you cannot make a diagnosis of SIADH. Then the other laboratory findings are the presence of low serum uric acid because of the dilutional effect, and decreased BUN. Now we talk about the clinical features of SIADH. So there will be the dilutional hyponatremia, and because of this hyponatremia, the patient will be having nausea, vomiting, decreased appetite, muscle weakness, can be confusion, drowsiness, seizures, coma, and death. We talk about the treatment of SIADH. The most important treatment for either acute or chronic SIADH is the fluid restriction. So we advise the patient for the fluid restriction to 1 to 1.5 liter per day approx, and we'll assess the urine output in such patients. And additionally, because such patients they are having hyponatremia, we advise for increase salt capsules and increase salt in diet. And for treating SIADH, we should also treat the etiology of SIADH. So etiology can be various. SIADH can be due to drugs like carbamazepine, chlorpropamide, and we should also see if the cause of SIADH is due to the post-operative pain. Sometimes it is due to the post-operative pain. So you have to relieve the pain of this patient. Unless and until you relieve the pain, the SIADH will not be corrected in such cases. And if it is due to certain cancers like lung cancer, then you have to treat either with a chemotherapy or surgery. There is also a role of loop diuretics like furosemide. It will impair the free water reabsorption in the tubules, and that will lead to the loss of free water in the urine and the lower urine osmolality, and that will promote the larger excretion of the water in the urine. There is also a role of demiclocycline, and the dose is usually 600 to 1200 mg per day. And how demiclocycline is effective in SIADH? So it induces nephrogenic diabetes insipidus, and thus it leads to increased water excretion in the urine. However, in children we cannot use these drugs because demiclocycline is associated with there is bone development is hampered with the use of this tetracycline category drugs, so it should not be used. In such cases we can use the lithium. Now in certain rare cases, if the SIADH is leading to severe SIADH, we can also use the 3% NaCl. And what is the reason behind it? The reason is the osmolality of 3% NaCl is 1026 milliosmol per kg, which is greater than the urine osmolality. And when you give this 3% NaCl, which is having the higher osmolality, that leads to the excretion of this excess of free water in the urine. And usually for a 1 liter of 3% NaCl, excess of 700 free water is excreted in the urine. And the last is the advice for increased protein intake. So friends, if you like this topic and lectures, please subscribe my channel. I would be happy to make another videos for you. Thank you.